Assalamu alaikum. The short clinical day. First station about nervous system examination. Please examine 21 years old gentleman presented with weakness. Examine his lower limb.
Okay, first I will come to the station. I will wash my hand and I will read the instructions. Then I will say to the patient, hello, I am Dr. Ahmed. Thank you to let me examine you today. If you feel any pain or discomfort, just let me know. I will take 2 steps away and I will make a general look over if there is any walking aid, anything beside any special shoes or something, anything.
There is stick.
There is a stick, okay. Then I will tell the patient to move all his limbs as once, both upper limbs and both lower limbs. There is weakness where else?
He can move upper limbs freely, but regarding lower limbs, he can upright. He can straight it, but not fully.
Okay. Then I will go to for inspection of the lower limb. If there is any wasting, if there is any scars or there is fasciculations or
No.
abnormality in the foot, anything?
No. Normal inspection.
Normal by inspection. Then I will go to making lifting. I will catch both the side and will see the lifting, and also I'll make rolling for this both knees. Okay. Then I will make the tone. I will make circumduction around the hip, then flexion and extension of the knee.
Okay.
There is any hypotonia or hypotonia?
Hypertonia.
Hypertonia, both lower limb the same?
Yes.
Okay. Then also I will continue to the ankle also, the circumduction also for the ankle. Okay. Then I will see the power.
Sorry. First, you examine the power around the hip. Yeah.
Yeah. No. I make first the tone.
Just
around
okay.
the hip.
Okay.
Still I will come to the power. Okay. Then the power of the hip, I will make him to raise his thigh up.
Okay.
And I will compare it by making his thigh down. Which is more strong, the flexors or extensors?
Okay. Extensor more powerful than flexor. Flexor weaker.
Okay, so flexors are weaker. Okay. Then I will make him to make the adduction and the abduction. Which is strong, the adduction or abduction? And the side.
The abduction is powerful than adduction.
Abduction is more powerful than the abduction. Okay. Okay. Then I will go to for the knee also. I'll make the power by extension and flexion. Okay.
Yeah.
And also I go to the ankle. I will make the for movement power up, down, and eversion and inversion. Okay, by resistant movement. Okay. And the distal and proximal, which is weaker?
Distal weaker than proximal.
Okay. Then I'll go to for the reflexes. I will make the knee reflex. There is a hyperreflexia.
Hyperreflexia, yeah.
Okay. Then I will make the ankle reflex.
Hyperreflexia.
Babinski.
Positive Babinski sign.
Bilateral. Okay. Then I will make also the clonus.
Positive clonus.
And I will make the patellar reflex. Pathological patellar reflex and the adductor reflex.
Equivocal.
Equivocal. Okay. Then I will go to for the coordination. It is difficult because of the weakness.
Yes.
Yes. Then I will go to the sensation because of the time. I will make the light touch first. Any sensory level, I will start both lower limb, one side, and by compare, first I will make him on his head, and to this will be the touch. You feel like this? Tell me.
Okay, which now we are examining the touch sensation, yeah?
Yes.
Okay, impaired touch sensation.
Where? Up to
Absent,
which
yes.
level?
Up to up to the umbilicus.
Up to the umbilicus. Okay. Okay. Then I will go to for the vibration and the joint position. The vibration.
Intact.
Intact vibration, and the position.
Position sense intact.
Intact. Okay. Then the pin break, I'll make it the last thing, and I'll make the patient to walk to see his gait. He uses his stick, and also I want to see his back. Sorry, before the gait. There is any scar?
Okay. No scar in the back.
No scar in the back. Okay. I finished my examination.
Okay, present your case.
This man, he did use a stick. He has a form of upper motor neural lesions. There is hypertonia, there is hyperreflexia, there is upgoing plantar. The coordination cannot be done because of the weakness. And sensation, there is sensory level up to the umbilicus. But here in this patient, the abductors is weaker than the abductors. Okay, for differential diagnosis.
What is your differential diagnosis?
It can be the proximal myopathy.
Proximal myopathy. Is distal more weaker than proximal?
Distal is weaker than proximal, but he told me abductor is weaker than adductors, or abductor. Which is weaker, adductor or abductor?
Adductor weaker.
Adductor weaker. Yes. It can be.
Sorry. I make it no. It will be the abductor weaker.
Okay, so like this, it's okay. This is upper motor neural lesion. The abductor is stronger than the abductor. Okay, so this patient is for differential diagnosis. Maybe there is trauma or tumor or TB, maybe transverse myelitis or disc prolapse.
Okay, so how you will investigate this patient?
First investigations, we will do the routine investigation, the CBCR, FT, LFT. And also we'll do for this patient imaging of the spine. We'll do MRI spine because he has sensor level. And also we will do for this patient, besides the imaging, the labs and imaging also. On MRI brain, just MRI brain will be the most important.
Okay, so for this patient, what's important part in examination do you want to examine this patient for?
Important part to examine this patient, the spine.
The back, you mean?
Yes.
You already examined the back. You had just an inspection, but you need to touch the back, isn't it? You need to touch the back because if there is a focal neurological symptoms that maybe he has fracture or dislocation of the vertebra, or even POTS or anything, you need to touch if there is tenderness or anything, maybe abscess. So you need to touch the back. Apart from the back, what else?
Examination, I should examine the cranial nerves and also the upper limb.
What do you think? What you'll find in the cranial nerve? What do you suspect in cranial nerve in patient with paraplegia?
No, I'll do it as a part of the neurological examination to complete it.
Okay, what else?
What else? The neurological, the cranial nerves and the gait and the upper limb and lower limb. All
Do you think maybe this patient has cord compression, or do you want to examine or ask about the bladder
urine
function?
filter. Yes, bladder and the bowel functions. You mean? Yes.
So this is very important. What things in the spinal cord can cause a affection of? Do you think that this patient now? Let's see. This is patient now. He has level, sensory level.
Yes.
Okay. Can you describe the sensory level?
This sensory level, there is the absence of the superficial sensation, the light touch, up to the level of the umbilicus.
Okay.
Okay, this about I think T4. I think I don't remember.
It will be the umbilical around 10 T10 to 12. Yeah.
T10. Yes. Yes. T10. Yes. T10.
Okay.
Okay.
Okay, so most probably the lesion come from outside to inside because it's affected it affects the superficial sensation more than the affection of deep sensation.
Yes.
Okay. Okay. Thank you.
Thank you, doctor.
كده.
Perfect. Thank you, Dr. Maida. Let's well done, Dr. Ahmed. Let's hear the comment from Dr. Maida. Please start.
Okay. So this is case of paraplegia, spastic paraparesis, with focal paraplegia with level. So with sensory level, that means there is focal cause for that. As Dr. Ahmed said, it can be compression. The compression will start from the vertebra. That's the only thing that I want from Dr. Ahmed to do. Generally, he did very well. What I want to see in this case that he touched the back, because most of the paraplegia, spastic paraplegia, the cause in the back. Most of the cases, still we need to to do if it is cranial paraplegia, it will be from the sagittal part of the brain, and this is also caused by meningiomas or tumor inside the brain. But we'll find the affection of the bladder more earlier in this case. So this patient, we think about focal cause of the symptoms. We need to examine the back for any something compressing the cord from the vertebral deformities, disc prolapse, or Pott's disease. That's why we need to examine the back still. It can be also leukemias, like leukemia deposit inside the brain, inside the spinal cord. Not spinal cord, in the meninges, I mean. Transverse myelitis as well. This is also it can be a vascular spinal artery, anterior spinal artery occlusion. Also, it comes with level, because the in case of vascular, the anterior spinal artery, its occlusion can cause the sensory will be there is sensory level as well. In this case, why we need for the investigation, we add to the investigation echo to exclude atrial fibrillation or anything like that. But generally did well. I think in this case, I will not complete my examination by cranial nerve. It's okay. You said I will complete by cranial nerve and upper motor neuron. And the upper limbs. But it's important part to examine this sagittal area, to examine the sensation in S1. You just mentioned it, and to examine the bladder and the back passages, because if there is cord compression, this is very dangerous. Need urgent attention in this case. Thank you.
Yeah, thank you, Dr. Maida.
Thank you.
It's yes, nice case. But I want just to comment on the meningioma. It won't be with sensory level. Parasagittal meningioma would be spastic paraplegia without sensory level, right?
Yes, I mean meningioma in the spinal cord.
Okay, at the level, yes, okay. Yes, okay, this is accepted. Meningioma at the level of the same area of the lesion, T10. Yeah, it's okay like this. So to remember the pathology, we have to first localize the lesion or the level of the lesion. And you can classify as Dr. Ahmed did, from inside, from outside, or infection. So you can mention the 3 T's: tumor, TB, and trauma. Tumor, TB, trauma, right? This is as in general. But you can also put space occupying lesion at the level, as Dr. Maida said and mentioned. And anterior core syndrome is one of the differential, particularly if you have a history of clots, blood clots. So you have to say, I would like to complete my history, taking history about any previous blood clot. This is regarding anterior core syndrome. It's one of the most important differential we should mention here. Why? Because we have sensory level without deep sensation or dorsal column affection, plus the pyramidal, and the pyramidal already in the anterior part of the cord. This is the most strong differential here. Transverse myelitis, okay, can be any compression from outside, any compression from inside, or any disc. All these causes can be there. TB and Bot's disease, trauma, as I said. This is regarding the pathology. The investigation, we can do again in the same manner: general, specific, bedside, and image ended by invasive test. I will ask Dr. Ahmed in this manner how you can give me the investigation as general investigation. What do you
General
think?
investigations include the CBC, RFT,
Perfect.
LFT,
Yes.
yeah, TSR, C-reactive protein also.
Perfect. This is for inflammatory, for example. And coagulation profile, don't forget. It's important to mention coagulation profile, because you might have thrombosis, as well as you might have coagulopathy, and patient will have bleeding, for example. A specific investigation here you can do.
MRI, it's fine.
No, image. This is image. A specific investigation. You can suspect the cause and do specific investigation for the cause. For example, TB. You can do.
CSF cytology.
Sorry.
CSF if needed. CSF cytology maybe.
CSF, if you suspect what?
Infection.
I think infection will not be diffuse. Even transverse myelitis is not investigated by LP. I talk about TB itself. Yeah,
Yes.
exactly, TB. So you can investigate for the TB or any tumor markers, for
Brucella
example.
also.
Brucella, yes,
Brucellosis.
perfect. Yes, perfect. This is for the investigation as bedside. Don't forget the lipid profile and thyroid function test as doctor, because also we have to rule the cause of thrombosis, as well as coagulopathy or hypercoagulable state for anterior cone syndrome. Bedside test, what do you think? Bedside test. It's very important. Any neurophysiological study, you have to do it as bedside test.
Blood
Plus-
pressure or
Plus echo neurophysiological study, nerve conduction
yes, nerve
study,
conduction.
and echo Holter, echo and Holter and ECG again for AF and precipitating factor for thrombosis. The last thing, the image of choice here.
MRI.
Yes, definite. And if you suspect cancer, you can do
You can do also CT scan.
CT cab. Yes, CT cab. If you
Yes.
suspect a cancer. The invasive test, I think it's not logic here, or it might be not helpful in this condition. The management plan will be according to
Multidisciplinary team.
yes, started by this.
And
Okay.
yes, will non-pharmacological and pharmacological.
Okay, before the
And the
pharmacological,
surgery.
very important team in this scenario. I usually mention.
The physiotherapy, the
Perfect.
social workers, and also
Remember,
and
physiotherapy, two teams in the physiotherapy, limb physiotherapy and occupational therapist.
occupational therapist. Yes.
Yeah, this patient might need a stick or wheelchair. He might be provided with the team. And the pharmacological according to the cause. Do you think multiple sclerosis could be the case or differential? Multiple
Yes, it can be.
sclerosis. Yes,
It can be. Yes.
it's possibility in young Asian female with the, but supposed to have also the history, full history about disseminating lesion different in the time and spaces, right?
Yes.
So we can consider MRI brain, MRI spinal cord. Vitamin deficiency as well. We can suspect vitamin B12. It might be also the case. Subacute combined degeneration, I think also it could be. But against subacute combined degeneration, we don't have peripheral neuropathy.
Yes.
Okay, transverse myelitis, you have to screen for virology, right? See viruses.
And
Okay,
transverse myelitis.
yes, if you suspect viral infection, you have to screen for viral screening. Any question or any added point, Dr. Maida, in this scenario? Or in this, what I mentioned already, I explained. Do you think, is it one of the differential? So what was the case? Exactly. Or you just put it for differential?
For differential, but transverse myelitis, I put in my mind first.
Yeah, perfect. Okay. So any question, Dr. Ahmed, Dr. Maida, before moving to the
No,
next
excellent.
scenario?
No, thank you very much.
Yeah.
Yeah. Okay, Doctor, any question from others or comment? Any suggestion?
For
Don't forget.
transverse myelitis, does it cause anterior cord only, or it is both posterior, complete sensory level? I think.
Yeah, I think
Yeah,
it's
yeah,
to
right.
be all the level, not only anterior.
It will be
All the
complete,
level.
complete. Yeah, transverse. It this case I put it can be for differential. It is focal lesion for a compressive cord. It can be Pott's disease or even fracture or anything.
Yes.
You are right. Transverse myelitis, it will be complete.
Yeah, all the level
All
will
the
be injured. Yes, exactly.
all the sensations.
In the multiple sclerosis, sensation will be affected.
The what? The sensation?
And in MS.
Any area in the cord might be affected in this, in multiple sclerosis, right? Any
Will be
area.
affected.
Yes,
In
it might
sensory
be.
level, yeah.
Yes, not at the peripheral nerve, as spinal cord. So you might have anterior part of the cord affected. Even you can have dorsal column. You might have cerebellum. You might have the cortex and periventricular. But don't add the peripheral neuropathy to the manifestation. of multiple
طب
sclerosis.
cervical myelopathy دي بتكون differential
Cervical myelopathy, cervical at the level of cervical, you can say degenerative change.
باينة thoracic بقى thoracic
Yeah,
myelopathy.
but the level of the thoracic down, not in the cervical. Yes, at the level of thoracic,
Mm.
but not in young patient. Young patient, you have to put something running in families or specific disease in the young patients like multiple sclerosis. Even you can add vegetarian patient dependent on vegetables. Yes, as a vitamin deficiency, I mean acute combined degeneration. Clear? But for the old age, you can put the degenerative and disc prolapse as well. Any comment? Any suggestion, Dr. Marwa? Dr. Aisha?
No.
Okay, thank you. Dr. Aisha here. Parasagittal meningioma, Dr. Sarah asking. Parasagittal meningioma? No, not parasagittal. Parasagittal, you will not have sensory level. You will have only paraplegia without sensation affection. Spastic paraplegia or paraparesis. You will not have sensory level. Once you have sensory level and you detect the level, think about the spinal cord injury, either from inside or outside, as I mentioned, or inflammation or malignancy. Okay? Differential, Dr. Sarah asked about differential. As we mentioned, 3 T's you have to remember. 3 T's. T for tumor, T for trauma, T for TB. All of them might cause this manifestation. Plus transverse myelitis if the all cord affected, and multiple sclerosis as well you can suspect in young female patient with history, and you have to complete your examination by taking history. I don't think the cranial nerve examination here is important unless you suspect, for example, cerebellar injury with multiple sclerosis. But if you will mention cranial nerve, you can choose optic nerve only as optic neuritis for multiple sclerosis. But cranial nerves will not be affected in multiple sclerosis, for example. Okay. Let's go to next scenario. Dr. Maida, your patient. I will present your patient, then you will start examination straight away.
I put on the chat box.
Yeah. You put already? Okay, 25 years man, Mr. Mark with abdominal discomfort. Please examine his abdomen. I will reset the timer. Ready?
Yes.
Here you go.
Sorry, just there is a sound. I want to make sure this is not for me.
The what? Chat?
Sound.
Yeah, we can hear you.
Okay. First, when I enter the station, I will first I will clean my hands. Say hi to the patient. Hi, hello. My name is Dr. Maida, one of the medical doctors. Is that okay to you? Examine you, and if you have any pain, just let me know. Hello.
Okay. Hello. Yes.
Okay, so I will start by general inspection around the patient if there is anything interesting.
Nothing.
Okay. I quickly have a look for his. There is a
What?
Can hear some sound. I don't know. Nick.
Yes, I am hearing you. And
Okay.
Yeah.
Now I think it's better.
Yes.
So I will start with general inspection. I will start by examining the hand. I will look for the clumping, colonekia, and I look for the leukonychia as well in the hand.
Normal.
If there is any sign, just let me know, okay? Then I will look for I will look for Duvitrean contraction in the hands.
No.
Okay. Then quickly I will have a look in the eyes if there is any jaundice or pallor.
No.
Go down quickly to the mouth, looking for angular stomatitis. I ask the patient to open his mouth if there is any interesting looking for the tongue and teeth hygiene.
No.
Then, okay, then I will go down, examine the back, have a general look for the back and in the front, looking for spider nevi, and also to look for sign of gynecomastia.
No. Normal.
I will go to inspect the abdomen, looking for any surgical scars and any distension of the abdomen, any scratch mark.
No.
Okay, then I will, okay, if there is any pain, just let me know. And then I will start by superficial palpation, looking for any superficial masses in the abdomen. Then I will examine the abdomen with deep palpation for the organs.
What organ?
So the liver.
Liver normal.
Liver normal. Then I will do liver span. If,
Okay.
is it normal?
How we do this then?
Okay, I calculate from the above from the nipple. I will percuss for the liver from the nipple downward, and then I will with percussion until I have the liver span, and I count it with my fingers.
Okay.
Okay, what is the liver span?
It's normal.
Okay, then I will go to examine the spleen for
Okay.
splenomegaly.
There is a splenomegaly about 5 fingers to the costal nerve.
There is splenomegaly about
5 fingers below the costal nerve.
5 finger. Okay, then I will do the examination to assess this is a spleen. I can't go above it and it go downward toward the umbilicus, and I can. I will search for the notch for the spleen. Okay. Then I will palpate for the both kidney. If there is any enlarged, not
No.
palpable. Then I will do percussion for looking for any ascites.
No ascites.
Okay, then I will complete my examination. I will ask to examine the back passages of the patient.
No need.
No need. I have quick look in the lower limbs, and this completed my examination.
Okay, no lower limb edema.
Okay, examination completed.
Okay. Okay.
Still 1 minute, Dr. Maida.
Okay.
You want to examine something else? If I ask you to do.
Yeah. Okay. So I do an examination. Look. I have 1 minute. This is good.
Yeah,
Then,
1 minute left. Do you want to add examination of something?
okay. I can examine by basal in the lung.
Yes.
By basal.
Supposed to. Yes, exactly. What else?
No bibasal crepitations.
Okay. I will examine. Okay. And what is spleen? Okay. Then I will examine the heart for any mermas or any.
No. Don't go to the heart.
But there is no liver. This is what I'm thinking. That there is no liver to examine the heart.
Okay, perfect. Okay, you're
what I'm
satisfied
thinking
with your
about.
examination steps? Okay, let's
Yeah.
go to the examiner. No problem. That's okay. I will tell you what you missed later. Examiner question, Dr. Ahmed, please.
Examiner, please present your case. The finding, your finding.
Okay. This 25 years old gentleman the positive finding in his abdominal examination, there is splenomegaly around 5 centimeter below the costal margin. This is the main thing that I found in the examination.
It is 5 fingers, so it will be 10 centimeter. Okay.
Yeah.
Okay. Okay. How you know this is spleen, not kidney?
There's 3 things that I cannot go above it. The splenic notch and not palatable.
Okay. What else? Okay. The movement was respiration.
You move with respiration, yeah.
Okay. Okay. Percussion. Dull.
Very
Okay.
yes.
Okay. Renal will be present. Okay. What is your differential diagnosis in this case?
Okay, for this gentleman with mainly splenomegaly and there is no hepatomegaly, I'm looking for infection, like viral infection, like Epstein-Barr virus. It can be tuberculosis as well, hematological disease like hemolytic anemias, leukemias and lymphomas, and myeloproliferative disorders. There possibility of also liver disease like causing portal hypertension like liver cirrhosis. The issue that I couldn't find liver, but it's still there is maybe a liver cirrhosis, so it's still a possibility that the patient it may be large because of portal hypertension, storage disease, infiltrative disorders like Gaucher disease and amyloidosis. The age of the patient, 25, yeah? So, yeah,
Yes.
it's still Gaucher. It can be one of the differential. It can be autoimmune, like SLE. And in this case, congestive heart, but again, it's that there is no.
Okay, I will comment in. Okay, what investigations we will do for this patient?
Okay, bedside investigation. Bedside investigation, including for this gentleman, what I'm thinking about no, I have bedside investigation to think about. A basic investigation, CBC, liver function, kidney function, CRP, and ESR as well. And this is the investigation. And then abdominal ultrasound and CT scan.
Okay, what do you search by the CT scan for what?
CT scan if this patient had a splenomegaly, and I look for if there is any sign of liver cirrhosis as well. It's ultrasound, I can see that, isn't it?
Okay.
Malignancies as well. Looking for any
Okay.
malignancy.
Okay, if I told you this patient diagnosis chronic myeloid leukemia, what else investigations you want to do?
Myeloid leukemia. Okay, so I will bone marrow. I will add for the investigation and.
What else?
Peripheral blood picture.
Okay. So if we thought this patient has huge spleen, as you mentioned, it is 10 centimeter. What is the indication of splenectomy in this case?
Indication if he has a trauma, if it can cause trauma. Then the other thing that's if the patient has low platelet count
Due to?
due to hypersplenism.
Excellent. Okay. What else? Okay. Oh. Okay. Suppose we have done the splenectomy for this patient, okay? After we have done the splenectomy, what we will do for this patient?
Vaccination from
Excellent.
capsulated bacteria.
What capsulated bacteria? You know?
Yeah. Haemophilus influenzae,
Excellent. Yes.
pneumococcal, and
Excellent.
not Neisseria gonorrhea, meningitis. Neisseria meningitis.
Meningococcus. Yes, meningococcus. Yes. Okay. If you will give prophylactic antibiotic, what we can give?
Prophylaxis.
Yes.
Septarine, what is the name?
Okay. Proximsal penicillin or erythromas. Okay. We will come. What other prophylaxis you can give for this patient?
After splenectomy, you mean?
Yes.
For antibiotic covering both.
Antibiotic, we told regarding antibiotic, also we give malaria prophylaxis also.
Okay.
If there is threat, okay. Suppose this patient with splenomegaly, he has deformity in his fingers. What you are searching or what is your diagnosis you are suspecting?
Splenomegaly and
He has deformities in his fingers, in the arm. Deformity.
I didn't take it.
Okay, okay. I will tell you. Okay. طبعا excellent يا دكتورة. هو طبعا approach طبعا excellent. Just you missed the lymph nodes. This is important. In abdominal case, you have to see the neck lymph nodes and even the axillary lymph node.
Yes, you're
It is
right.
important. This is important. I see also in some of the videos in the tube, they are also measuring the pulse. Also, maybe because of medications for transplantation or something. Sometimes they are also measuring the pulse. Okay. In this case, you have this is huge splenomegaly without the liver. Okay. Also, I am studying with you, and I'm reading also. Just this huge splenomegaly, the differential diagnosis will be chronic myeloid leukemia. It can be myelofibrosis, but this patient is young age. It can be malaria, and it can be Kala-Azar visceral leishmanias. Okay, because this huge splenomegaly is more than 8 centimeter. Okay. If you have the moderate splenomegaly from 4 to 8 centimeter, it can be due to portal hypertension, as you mentioned. You search it for the liver affection, or it can be lymphoproliferative disorder or myeloproliferative disorders. Okay. Mild splenomegaly included the other causes like hemolysis, chronic hemolytic anemia, infections, infective endocarditis, Epstein-Barr virus, HIV, typhoid, infiltration, amyloidosis, sarcoidosis, autoimmune, also like rheumatoid arthritis, that is Felty syndrome that I asked you regarding, splenomegaly and the deformities in the fingers. You will suspect rheumatoid arthritis. We'll do for this patient CBC. We'll see the neutropenia. Will be the triad, neutropenia, rheumatoid arthritis, and the splenomegaly. Okay. Also, splenic vein thrombosis and the splenic abscess also can be. Okay. The investigations you will do for this patient, including the CBC, including the blood film, important because of the hematology. Okay. The liver functions, LDH, autoimmune profile. You can also have the HIV and also the malaria. As you mentioned, the abdominal ultrasound is important, and also CT chest, abdomen, pelvis. You look for the malignancy, and also you will look for the lymph nodes. And if suspected, also can go to for big CT scan. If you found the lymph node, also you can do for excisional biopsy and bone marrow biopsy if needed. What I told you regarding chronic myeloid leukemia is the Philadelphia chromosome translocation 9 and 22. This is important in chronic myeloid leukemia because treatment will be targeted against this translocation. Okay. Regarding the indication of splenectomy, as you mentioned, the trauma rupture and also the huge spleen that cause perishal symptoms and hypersplenism and increased need of backdoor disease. After splenectomy, as you mentioned, they will do vaccination against encapsulated bacteria, pneumococci, meningococci, and the H. influenza. And also there is prophylactic antibiotic, oral phenoxymethyl penicillin or erythromycin. Also malaria prophylaxis, and there is also can be a medic alert bracelet. Okay. But nice, doctor. Also, the causes of hyposplenism in this, if there is hyposplenism, but what is the causes? What's your opinion? Just to provide.
Sorry, the question here.
Causes of hyposplenism, not hypersplenism. Hyposplenism.
Like sickle cell.
Excellent. This is autosplenectomy, sickle
Yeah.
cell disease.
Mm.
What is the other causes? Also celiac disease. You will find hyposplenism, and also splenic artery thrombosis. So you see splenic artery thrombosis making hyposplenism, and the splenic vein thrombosis making splenomegaly. Okay. So this is but excellent, doctor. Only just you miss this lymph nodes. Also, when I started preparations, I was missing this lymph nodes also, but because even the time will be stressed, so we don't know what will occur in the examination. We hope that we will not forget, inshallah. Okay, inshallah. Okay, excellent. Doctor.
Well done, Dr. Ahmed, and nice preparation to the topic. So we will talk what Dr. Maida missed. For my side, I think if I'm not mistaken, she did a cytist examination, right?
I did my cytist examination.
You did.
Yes. She make percussion.
Okay.
Yes.
Percussion. Okay. And what about other end-stage liver disease or decompensated end-stage liver disease manifestation? You examine the whole, the back, the chest.
Yes,
Spider
Yes.
nevi.
chest
Yes.
spider nevi.
Yeah, perfect. Don't forget the back. You might have some spider nevi at the back. It's not only at the front. The other issue for the lymph node examination, I prefer to do it while the patient is still in semi-sitting position. After finishing the hand, you are holding his hand, right? Checking the pulse, checking for AV fistula, finish inspection and the palpation of if there is AV fistula. At the same time, you are holding his hand. Continue holding the right by your right hand. Examine for the right axillary lymph node by your left hand. And at the same time, do the left lymph node by holding his left hand on your left hand and examine by your right hand. In this way, you will not forget the lymph node. But if you forget initially and, for example, you are doing it at the end, with the time, you might not have the time to do the lymph node examination. So I prefer to do it earlier. It will not take 15 seconds or 10 seconds for each group.
Sorry, Dr. Batul, to interrupt you. Also, something I forget because we are not
okay,
seeing
go
the
ahead.
patient.
Say.
Yes, sorry. Also, in superficial palpation, we should go down. I think in the superficial palpation and look to the eye of the patient regarding tenderness.
Yeah, don't forget to
Yes.
look at his face for the
Yes.
tenderness. This is for
Yes.
any examination of palpation. Legs or tummy, abdominal examination, you are checking for tenderness, look at the patient face. Even
And
gynecomastia. Yes.
yeah. The bed also should be on a flat position. Yeah, and maybe
This,
you will enter
exactly.
the station, you will find the patient semi-sitting of 4 to 5 degree. If you have not
Perfect.
making the abdominal examination flat
Yeah.
position, they will
They will
minus
fail
us
you.
in the examination.
Yeah, they might fail you. Yes, you're right. So remember, after examining the liver for pulsating GVP or raised GVP, this is the time to make the bed down. If you forget, they will minus you. This is regarding the steps. I think Dr. Maida did all steps perfectly, and she catched the case. But I prefer once you have huge spleen reaching to the umbilicus to specify the causes of huge splenomegaly. Dr. Ahmed mentioned already CML on the top, myelofibrosis, malaria, and leishmaniasis, and Gaucher disease as. But the first four are common. Gaucher if you have inherited condition, but you have to mention it whenever you are mentioning the causes of huge splenomegaly. Clear now about the causes? Of course, these causes will be related to isolated splenomegaly. Okay? Any question regarding the previous talk? Now we'll talk about the investigation. Again, I will ask Dr. Maida how you investigate these patients.
Okay. I don't know the bedside. I'm trying to find a bedside examination for him. I can't. Yeah, maybe blood sugar. I will do. Then general investigation, including bloods, and including CBC, liver function, kidney function, and then specific examination for ultrasound and CT scan.
No. Always mention the ultrasound and the CT scan in the image.
Yes, this is the image.
Yeah. Okay, there is some specific tests in this scenario. What do you think about?
If I'm thinking about leukemia, I will.
Perfect. Yes, that's specific for the cause. Leukemia, I will look for blood film, bone marrow.
Then blood film and bone marrow. And then if I'm thinking about malaria, I will.
Perfect. Yes. What about malaria? What you will do? The same.
Malaria test, yeah.
Yeah, blood film as well. Thin and thick for malaria. This is for malaria. What else? For Gaucher, for example, what you will do?
Genetic.
Exactly. Yes. Or I think lipid storage disease. I'm not sure about is it genetic or something else. Is it called genetic? Or fat metabolism? Something in the I think enzymatic, not genetic, right? Enzymatic.
Say.
Okay. So these are the causes, and we already investigate specifically about each cause. Now we'll talk about the management, how you manage this patient.
Okay, non-pharmacological by education the patient. By education the patient about the disease, if I know the disease, and MDT, including hematology, gastro, and medical team as well, and then the specific treatment according to the cause.
Okay, these are the non-pharmacological. The pharmacological, what you say? What you think? Dr. already Ahmed, I think, mentioned it. The vaccination, according to the cause, and vaccination is important.
Yes.
And the surgical management or intervention according to the need, if there is manifestation or hypersplenism. Yeah, exactly. I think this is the case, and we already discussed before the causes of spleno and hepatomegaly or hepatosplenomegaly. And this scenario, we talk about isolated a huge splenomegaly. Differential diagnosis already mentioned the causes of huge splenomegaly, and the investigation and the management plan. Clear about this case and topic, isolated huge splenomegaly? Yeah, enzymatic assay. Thank you, Dr. Hassan. Gaucher for enzymatic, not genetic. Okay, any question? Someone wrote examination of lymph node axillary should expose close. By the way, not the lymph node, the whole abdomen station, you have to expose the patient. If you don't expose the patient, they will minus you hardly. If you examine on the close, you will blame yourself.
And there is already a scar in this situation,
Yes.
For splenomegaly, particularly,
Yeah.
you should expose the axilla good and look before feel, because because we used to examine the axilla without seeing, because it is
Yes.
armpit, so you will making the patient hand holding
Relaxed.
on your
Yeah.
relaxed, and you will not look.
No,
And
no
in
look at all. Just
specific,
palpate. Yes.
no, in splenomegaly you should, if it is isolated, especially because a lot of cases come with the scar in this area for biopsy.
Okay. So you have
So
to look plus palpate.
in
Okay.
splenomegaly especially, don't miss
Yes, you're
the
right.
lymph node, and don't miss to look about biopsy. If the
Yes.
case all is splenomegaly only, especially if it is large spleen like this case, if it is
Yes.
very big spleen, and only the discussion will be like if it is lymphoma
Lymphoma.
or
Yes.
not. So you should or chronic myeloid leukemia or myelofibrosis. So he will ask you why you didn't examine the lymph nodes. And if there is biopsy, it will give you a big clue with the discussion.
Yeah. And
And
I
already
hope
it come in many exams to have a scar in
and
axilla.
the armpit. Yeah.
Yes,
I hope.
maybe the scar in neck, but it's not very frequent. But a lot will be in the axilla. If
Yeah.
they can take
Perfect.
biopsy from something hiding, they will
Yeah.
make to not disfigure the patient.
Yes. Exactly. But it's important to have a look, and I hope they will prepare the patient. I mean, the area to be clean and clear for
If
all.
they having this station for splenomegaly only or for biopsy, they will prepare.
Exactly. This
It's a
is
must.
my point. Yeah.
Yes.
So you must have a look plus palpation. Thank you, Dr. Aisha, for adding this point. It's important because it might be lost or missed by any of our candidates.
I missed my the lymph node examination in my exam.
Oh
But
my
really,
God.
it is very important. Especially, I
Yes,
always remember myself that it is usually the thing forgotten in this station.
that's okay. The stress
But
always,
yes,
yes,
so we should, even if you will forget in when splenomegaly, never forget, because
yes,
in splenomegaly, the discussion all will be about this problem.
exactly, yes. Thank you, Dr. Aisha, for this point. Anyone want to add another point? Any suggestion, any doubt? Clear for all? I hope the station would be easy for all of us. Any
Appreciated,
question?
really, Dr.
Yeah, thank
Bassos.
you,
Thank you
Dr.
very much.
Okay, Dr. Ahmed, thank you so much. Thank you, Dr. Maida. Again, nice session. And it's reminding. Even you are not seeing, but still the steps you have to memorize. You don't have time to think in the exam. It's a matter of how to express, how to be confident in the steps of the examination, how to discuss confidently with the examiner to gain more marks. And the questions, believe me, it will not be out of this type of question. Present your case, the manifestation, the finding, what's your differential, what's your investigation, the management plan, 4 minutes. And thank you. Don't forget Dr. Maida, Dr. Ahmed at the end, cover the patient, thank him, and go to the examiner. Plus
Yes,
sterilization, yes, washing your hand before and after.
yes.
Any question before ending the session?
No, thank you. Just from your experience, Dr. Bassam, I want to ask regarding because this station abdomen and also chest after the communication. While preparation
Yeah,
for the communication, I will put in mind is that I will go to the chest and abdomen and I will think about the steps, or just it will depend
don't
on my
think,
work before, I think.
yes, yes, don't think about the steps. You have to do it subconsciously. I mean, you will go forward to the patient, introduce yourself, confirm the patient, I would like to do 1, 2, 3. If you feel pale or any discomfort, let me know. And start by the hand, continue step after step without thinking what would be the next step. You have to train till the exam, even at your home.
I
Train
think
on
he
any
means
of.
that he will prepare the most
No, no, no.
comfortable station for me. It was
Car-
the tooth examination because you will take rest outside. It is the only
yeah,
rest you will take in all stations. Because all
yeah,
station you will
yeah.
have
Other station, you are.
preparation out.
Yes,
Yes, you will
exactly. Yes.
take the minutes preparing for the case. And this is after the case, we will take the other case. You will be direct regular. Is the only rest is with this station because to examination, so no paper outside, nothing outside. You will look for the
Yes.
up and you will think or you will making anything to relieve your stress or like that. So it is the most preferable station really.
Yeah, the cardiac and neuro, as Dr. Aisha mentioned, this is the only step you will sit alone, not writing anything. But I prefer, as Dr. Aisha said, uh, remind yourself what tricking steps you have to do and to remember in the cardiac and the neuro. For example, in the neuro, write the gate. I believe most of us forgetting the gate.
But where he will write? No paper he will take in this
No, no, no,
stage.
no, no, no. There is. You have a lot of papers, all the stations.
No paper he will take in.
No, no, you will not take in, but you remind yourself outside by writing.
Yes,
Then
maybe
when
by steps.
yeah,
Yes, yes. It is
because
good
whenever you go
idea.
inside, yeah, whenever you go inside, believe me, you will forget the steps. This is the first, the gate. Sorry, the gate. You will forget the gate. This is for the neuro.
Yes,
For
the
the
gate
guard,
always forgotten. Yes.
exactly. So you have to write it down in your paper. The gate, cranial nerve, for example, the back, all the things you are saying while training. I would like to complete my examination by doing 1, 2, 3. Try to write them in the paper. I would like to continue my examination by doing 1, 2, 3. Because whenever you are going inside, you will forget this completing your examination by doing 1, 2, 3.
This is Dr. Bassel before the neuro and the cardio, but
This
before
is
the chest
for,
and
yeah,
the abdomen, we will
just
enter from the communication.
exactly straight away.
The time,
Yes,
the time is yes, the time is يعني very short to prepare also the examination. You will always focus on the communication or on the long case
Yes.
because it is long, very long scenario. You will take 2 minutes reading only the scenario
yes, you will read the scenario. You might,
and repeat it because the
yeah,
the
exactly.
concentration not very good. Yes,
Only reading, you might read the scenario, for example, 2.5 minutes. Because of stress, you might read the scenario, you didn't get anything, you read it again, you read it again and again.
and you will take notes during reading. So
Exactly.
it will take.
Yeah. It will take time, and you have to focus about the task, the other support, for example, social, driving, smoking, alcohol. Write them in your paper and try to get the scheme for your scenario. For example, counsel about the disease, you can write some point what you have to talk about: pathology, manifestation, complication, management plan, investigation, and so on. Write them in highlighted points, not in details. Okay. While you go inside, you can explain according to the patient or the surrogate talk. What he asks you, you will answer, or you have to talk about the main task earlier before he will ask you in this way. But you can prepare yourself in the communication scenario. The chest and abdomen, no preparation. You will just leave the surrogate from communication, going forward to the patient. You will do in confident way. If you are hesitant, you'll be hesitant, believe me. Clear, Dr. Ahmed?
Yes, thank you very much, really, for your advice, Dr. Bassel. Thank you very much.
Most welcome, Dr. Ahmed. And you are welcome anytime if you want to practice before your exam. I know it's about a couple of days. If you are interested
Yeah,
any day,
next week. Yes.
any
Okay.
question also, you can send me anytime.
Really, thank you very much. Appreciate it. Really. Thank you very much.
Okay, best of luck, Dr. Ahmed.
Thank you. Thank you. We hope.
Thank you.
Thank you.
Any other question from others? Dr. Maida, any question?
No, thank you. Thank you very
Okay, thank you too. See you, inshallah, after the weekend. Have a nice weekend. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullah.